Mr. Samir Mehta is a healthcare professional with over 20 years of experience spanning the space of management and project consulting. He has programmed over 10 million square feet of healthcare space. That's quite a bit, quite a lot. And he has been instrumental in actualizing the establishment of design build services, the first such initiative in the domain of healthcare consulting in India. Currently, he is the director projects at Osmac India and leads a team of diverse skill sets to anchor the services of medical planning, turnkey design, project management, and equipment consulting and contracting. Today, the session will be speaking on the infrastructure, the planning of the infrastructure in the intensive care unit. Over to you, Samir.
Thank you, Dr. Shetty, for that introduction. And thank you, Keho, for this opportunity to share our learnings and practices in planning and designing critical care units. I have to admit, it is a little intimidating that I'm addressing the stalwarts in the fields. But I also hope you'll find some interesting insights and food for thought, and I shall be open to receiving your feedback at the end of the session. I'd just like to start with the preamble that I'm not going to get into textbook definitions here because you all are the experts in your fields. My objective will be to address some key planning decision points and issues. So as with planning a healthcare facility, so also with its critical care component, the intensive care unit, which is but a microcosm of the entire hospital. The need establishment is the first step in the process. We typically start with this, discussion around what should be the number of beds. Now we draw this from the business plan if it is available, and if it is not, we would engage with the client user group in an exercise called functional programming. So as much as we seek to hear their needs and viewpoints, we also share our learnings, all in a bit to zero in on the classification of the units, the number of beds in each such unit, the adjacencies, locations, and importantly, the component of isolations and its types. Generally speaking, a high percentage of critical care beds was not necessarily a smart proposition. However, with advances in medical care where a lot of patient care and management is being done on an ambulatory basis, admissions are getting relegated for the more critical care cases. So inevitably, the percentage of critical care beds in a tertiary care setup has risen from what used to be around 20 in the earlier times, gone up to 30 to sometimes even 35% of the total bed complement, which is sizable. Now the question is, what is an optimal size of an ICU? Clearly, resources are expensive, and without spreading them too thin, one needs to arrive at a balance where care is not compromised. We are advised that units of 8 to 12 beds are both administratively and economically efficient, not to speak of optimal infection control. A smaller number and resources are not optimally utilized, a larger number and the challenges begin to seep in. So of course, this can be mitigated to an extent by appropriate staffing, but long and short, 8 to 12 beds is what we found is to, an optimal size for a critical care unit. Now, the next question is, having determined the average size, do we need to classify? So there is this case for classification based on the need for staff trained for a particular discipline and specialty. So at times, there is this school of thought that medical ICU is not as clean as surgical ICU. Of course, this is nothing to do with cleanliness per se. It is more to do with this anticipation of the infectivity load. In others, the average length of stay warrants a separate unit, as one would in neuro, for instance, where the one may choose to overlook such considerations and combine different disciplines, be that medical or surgical. So while there are choices to be exercised here, you have this list, which could be potential distribution and classification of intensive care facility units in your facility. So while we exercise these choices, one point of discussion that in earlier times would typically be brushed aside, and I'm talking of my experience here, is no longer so, is the provision for isolation. It's just not about COVID, but there is a gradual realization that, this provision has to be deliberated, discussed, and provided for right at the outset. So while this audience, I'm sure, needs no explanation, for the sake of it, will like to mention that there are 3 categories of isolation for airborne contaminants. I'm making this distinction because we are not broaching contact isolation, which needs nothing more than elementary barrier nurturing. What we are broaching is, will include typically a protective room, which is to house an immunocompromised patient, and airborne infectious isolation, which, as the name suggests, will house an infectious patient. And then there is this third element of combined isolation, which will house a patient who's both immunocompromised and infectious. So CDC typically will not allow the reversal of one positive isolation room into a negative isolation room and vice versa, but has clearly endorsed this provision of a combined isolation room where you are able to house a patient who's both infected and immunocompromised. Speaking of size, ISCCM has come up with a revised recommendation recently that is fairly elaborate. It's a good document to go through, and I would urge everyone to look at it. It also, I think, draws a bit from FGI guidelines, which is Facility Guidelines Institute, that are referred to for Joint Commission accreditation. And these call for the provision of at least 200 square feet area with a head wall of, about 13 feet. I'm talking about the area requirement of a typical ICU cubicle, okay? This gets condoned to 150 square feet for renovation projects. And given a choice, we prefer rooms, but in India, more often than not, we have to contend with cubicles and bays, and at times an open plan arrangement. So in an open plan, a minimum of 8 feet may be maintained between two beds. So this is a bit about, how we size the bed spaces. A little bit about where we should locate the ICU. So there is a little difference of opinion among the medical and the nursing experts as to where the ICU should be located. One suggests that the ICU should be in a centralized place and be contiguous with or readily accessible to one another. This allows the specially trained professionals and equipment and almost instant access to patients in all units when an emergency develops. The second school of thought favors that the location should be dependent on the type of patients. For example, the surgical ICU should be close to the operating rooms, while the medical ICU should be in close proximity to the medical ward to facilitate the concept of progressive care, where the patient is moved from intensive care to intermediate care to, general patient care area. So that progression of care becomes a little easier, is one, point of view. But whatever its location and adjacencies, the intensive care unit must exclude any through traffic. The unit should be located to allow for seclusion from the busier public areas and thoroughfare, and that I think is a criteria that we try and focus on. A little bit about technology and humanity. In most ICUs, the focus, because I also am coming from a design perspective and a planning perspective, in most ICUs, the focus is not so much on a patient as it is upon a disease, whether we admit it or not. It's almost as if the procedures necessary for sustaining life in the physical sense were somehow not compatible with the simultaneous sustaining of emotional well-being. So this assumption seems to be, there is this assumption that seems to be that, the ICU patient is either unconscious or unaware of his surroundings or too sick to care about them. But we know that is not true. So the sense of claustrophobia that is created by the monitoring equipment, the respirators, the IV delivery equipment, all crammed into a small space can increase anxiety levels and make the patients feel helpless. So design can help mitigate this to an extent. Windows are all too often absent from an intensive care unit design. Not only does this heighten the sense of claustrophobia, but a number of studies have demonstrated that patients in a windowless room are subject to something that I'm sure most of you are aware, ICU psychosis. So in some states, it has become mandatory to provide a room with a view to counter the disorientation that creeps in following prolonged stay in confined spaces. Standards, especially accreditation standards, now clearly stipulate that there should be no more than one bed space between a patient and a window. So if a patient is in a remote, bed space away from the window, you cannot have more than one bed space between the window and the second patient. This is what the standards initiate, all in a bid to ensure that the patient has access to natural light. The other important thing is that the constant beeps and drones of equipment do very little to alleviate the cold environment. The noise can be stressful and the pain perception tends to get heightened. But these machines are important. It's not that I can dispense with the machines. So the best solution, therefore, would be to opt for a design with rooms. Of course, it calls for a little more area. But that's a call we should take, what is the priority we accord to patient comfort. So we can opt for a, design with room instead of an entirely open plan. Or one can use acoustically lined metal ceiling or hygiene grade fiber ceiling with a good acoustic property. And instead of using a hard floor, one can choose rubber, linoleum, or vinyl sheets. These measures, let me tell you, certainly help. From these patient-centric, suggestions, we move to what goes behind the scenes, when we undertake planning of critical care units. So I'll touch a bit upon the engineering aspect of it. Insofar as electrical and data is concerned, we make it a point to provide at least 12 power receptacles per bed space. So there'll be 8 on the bedded panel or the pendant as you would, choose to go with. There will be 2 on the head wall and 2 towards the foot end. These 12 power receptacles that I speak of will include 1 for the electrical bed and 1 for the mobile X-ray. It is very important, this is a point I want to make in the interest of patient safety and the user safety, that these are routed through what is called an isolation transformer, because it will allow both safe and continued power supply. For those who would like to know, if they want to brief their team, the load, electrical load for a typical bed space will range between 2 to 5 kilowatts. That's a brief that you can share with your design team. Another important provision that we try and make is that in the equipment bay, not only do we give you a large counter, but we provide you with multiple power receptacles, because that's where you'll charge the syringe pumps and the infusion pumps. So it becomes an important criteria. Data cabling is of course required for central monitoring, and nurse call, of course. The regular nurse call allows the patient to speak. But what becomes critical in an intensive care setting is the provision of code blue. I mean, we no longer follow that traditional approach of alerting the nurse station, which in turn will alert the PA system operator to make announcements through the hospital. You would never know if the team assigned has heard or will acknowledge the call. So we now have systems where the assigned code blue team are given pagers. This allows them to respond without loss of time, and the ICU staff too knows that help is on the way. Equally important, other members of the code blue team will know that the other person has responded, so they can stay put and continue with their work. I think this is one simple but important element of design that more hospitals would do well to follow. From power to lighting, we try and avoid harsh lighting overhead because it contributes to the discomfort of the patients. We can address the lighting requirements by way of using daylight fixtures with acrylic covers, okay, so that no dirt accumulates. You do not need clean room fixtures in an ICU setting. And while the lux levels for general lighting would average 150, that for examination will shoot up to 750. Now these, requirement is easily, addressed by using gooseneck lamps for examination. That's how it becomes easier to manage the patient. The third element of engineering that I would like to broach is air conditioning. Now, we all know that the design temperature in our ICU setting is 21 to 24 degrees, and it's important to maintain the RH also between 55 plus minus 5%, so 50 to 60%. Very important, we maintain a 2-stage filtration, which is a coarse filter and a microwave filter, and a minimum of 6 air changes per hour. Now, this is important because otherwise there is a buildup of contaminants and the environment can get not too healthy. The protective isolation room, unlike the rest of the ICU, if we have agreed to have a PE room or a protective environment room, then it must necessarily be equipped with 3-stage filtration, which means that you need HEPA, and that particular room has to be maintained at positive pressure. If you have an infectious isolation room in your facility, then that will not allow for recirculation of air and has to be maintained at negative pressure. You do not necessarily need an anti-room, as convention would have you believe, because if you don't have the space, you can still be compliant with the norms by ensuring that you have a hermetically sealing sliding door. However, if you have a combined isolation room, an anti-room is totally necessary, because this is a space that is going to be maintained at higher pressure relative to both adjoining spaces. So let me try and see if I can help you understand this with an example. This is a very elementary depiction of a patient room. If you notice, the access is through an empty space, and which is marked with 3 positives, which means that the pressure here is at the highest. This is an illustration of a combined isolation room. The whole objective is that a patient who's inside and is infectious and immunocompromised will be in a situation where the air from outside, which is from the corridor outside, will not get into the patient space because the anteroom is at a relatively higher pressure. Likewise, air from the patient room will not get into the corridor outside because the anteroom is at higher pressure. So this, very simple and elegant engineering principle of maintaining the anteroom at highest pressure will allow you to maintain a patient who's both infected and immunocompromised without any risk to the world outside. So this is something that I thought is not very commonly known, and I could share with the audience here. Going forward from air conditioning, I'll touch a bit about plumbing. So in addition to the nurse stations where hand washing fixtures should be conveniently deployed, we also try and make provision of hand washers right outside the bed spaces. Now, there are two schools of thought here again. One which says that in the Indian context, people will not maintain it, it will tend to get dirty. But if you do not make this provision, you are not really enabling the caregiver to ensure that he or she washes his or her hands between seeing the two patients. So we believe that this is a good provision to make. Then the other plumbing provision that becomes important is the provision of RO treated water, which is required to facilitate conventional dialysis. Now we try to make this provision at each bedside because you never know which patient is going to need dialysis. It is important that if we make such a provision of water supply, we should also have a provision of a drain with an appropriate trap. Now, it's not enough to have a drain, where you can leave the tubing of the dialysis. It has to have a certain trap, which is called a roach trap, which will ensure that there is no reverse ingress of vermin from the drain. So this is a little bit that you can do towards ensuring a cleaner environment in the critical care unit. The dirty utility should be equipped with a flusher disinfector. Now, a flusher disinfector is, another word for slop sink, only that it is mechanized. It will require both cold water and hot water, and it will ensure that you are able to clean the bedpan, rinse it, flush it, dry it, disinfect it, and before it's given to the patient, all mechanically. A staffer does not have to do it. But if you cannot afford it, then of course you have the conventional slop sink, a tank to store diluted hypochlorite solution, in which you can immerse it and then dry it out and hang it out and then give it to the patient again for use. And one, provision that we do not fail to make is one assisted toilet in each ICU, because if you want to encourage the patient to use it, and if your patient is capable of using it, they'll be happy to do so. Medical gas piping system is another important provision. We try and follow HTM, which is Health Technical Memorandum 0201 as a standard, which stipulates provision of 2 outlets each of oxygen, medical, and vacuum for each bed space. We have something called the area valve and alarm unit, which will indicate variation of pressure beyond a permissible limit. And we try and place it close to the nurse station because it has an audio-visual alarm. These are some images that I wanted to share, which if you look at the one in the northeast, where my cursor is, which is an open plan ICU and is also equipped with televisions, which patients can use if they choose to. The one that you see on the right is actually a bed bay kind of arrangement, where you have the fourth side, which is the access side, open and which is controlled only through a curtain. And the one at the south is a kind, where you have room virtually with staff bays outside. So between 2 bays, you have a staff base which will oversee the 2 patients. It also has provision for a hand wash. Gerontologists often speak of an environmental docility hypothesis, which holds that as competence decreases, the probability that behavior will be influenced by environmental factor increases. We now know that critically ill patients often feel at the mercy of the environment, and this seems to be even more compelling among the critically ill elderly. Some of the design areas discussed earlier, especially noise control, light and color, are particularly important in designing with the elderly in mind. Noise reduction should be a high design priority. Because of diminished visual acuity in the elderly, light should be planned to avoid glare, which means that we should have no highly reflective surfaces. And color discrimination also tends to deteriorate with things. So differentiating among dark shades or differentiating among pastel shades is a particular problem. So we try and use contrast to emphasize planes and corners, which will aid orientation. As much as we speak of design, I will, so this is another illustration I wanted to show where we have the pendants, which means that we do not have a bedded panel. And this arrangement will allow you 360-degree access to the patient without getting, encumbered with wires and, tubings. So this tends to be a little expensive, but if you can, of course, allows you great access to manage the patient better. This is another illustration of a corridor. What it shows you is on the right-hand side, you have the bed spaces, but these workstations will allow the staff to be seated and oversee the patient, while also allowing, charting and of course, provision for hand wash here. This is another illustration of how hand wash, at appropriate locations becomes a very useful provision. And you have the staff base, which of course oversees the 2 patients here too. A little bit of the way we approach the process of planning. So space program is what we undertake, at the outset before we start designing. And typically, we have 3 sections to a program. This is the administrative control zone where we provide for waiting for the relatives of the patient in the ICU. Of course, you will need a toilet for them. There is a counseling room where you can discuss the, patient with the relatives. You have the grieving room where if you need to break news, then this is a space which allows the family to be and grieve. And of course, you need an office for the intensivist room. The patient's care spaces, if you note, we have the patient care, which we normally accord 200 square feet if the space permits. If not, we have to make the space a little smaller. And each set of 2 beds will have a staff work base to oversee the patient and monitor the patient. Isolation rooms, of course, will have an attached ensuite toilet. This is important because the whole objective of isolation room is to ensure that the patient does not have to step out. So this becomes an important criteria. You have an assisted toilet and a fairly spacious nurse station, which allows the caregivers to work conveniently with all its provision for central monitoring station, medicine, crash carts, refrigerators. And these are the support spaces, sometimes overlooked, but very important. You need a large equipment bay where you can park the equipment when not in use, a medication equipment room and a stat lab, clean utility, soil utility, a pantry, a staff room, which sometimes, gets sacrificed for want of space, a multi-purpose room, housekeeping closet, of course, also important air handling unit rooms, because that is what will allow you to maintain your indoor air quality and the toilets for the staff. So I'm open to questions.
Nice presentation, Samir. For your comment on dynamic lighting or circadian lighting to prevent delirium in the ICU setting. Can you comment on that?
Yes, I can. So we now have light fixtures which modulate to simulate the progression of the day. There is a company, if I can refer, because very few companies make it, you can look it up on the website also. It's called COELUX, which will give you a beautiful illustration of how this happens. So while you're in that space, you will never realize that you actually don't have a window, because the light changes much the way the day progresses. If the problem is to overcome the challenge of maintaining that circadian rhythm, then this is the answer. The only challenge, and typically so, is that it is awfully expensive. So I do not know whether we can afford to do it in each ICU bed space.
There's another question. What are the names of the 3 types of ICU design? I think you have commented on.
Actually to do with isolation, not ICU. Okay, ICU cubicles is one.
I think it was isolation.
ICU rooms is one, of course, where you have, if it is isolation, then of course we have the conventionally used terminology of positive pressure room, which is meant, or technically correct terminology would be protective environment room, which needs to be maintained with positive pressure through HEPA filtration, and which is intended for an immunocompromised patient. The second category is a infectious isolation room, which, as the name says, is for an infectious patient, has to be maintained at negative pressure. You cannot allow recirculation. And the third category is the combined isolation, where you can house a patient who's both immunocompromised and infectious.
Thanks, Samir. How many beds a ICU is recommended? I think it's about bed to ICU bed ratio?
The total number of beds that we are seeing now is in the vicinity of 25 to 30%, which is fairly significant. But that also, as I explained at the outset, is a function of the fact that more admissions are now happening for more critical, purposes. Relatively simpler things are getting addressed on an ambulatory care basis. So then those patients don't really need to get admitted in the first place.
Because I've also seen in many of the hospitals have varied kind of a proportion, not exactly uniform across the board, isn't it?
So tertiary care setups will typically need a higher complement of critical care beds as compared to a secondary care setup, for obvious reasons, of course.
Yeah. Thanks, Samir.